Maybe they'll be able to hear from here. Okay, so shift again. I don't know what the deal is this semester. We're having trouble with our guest content speakers. Professor Smith has a conflict that she told me about last night. So we're gonna do OB today. And then I'll have to get her. You guys just did psych, so you should remember psych. You should be good on psych. If we can't get it in, then I'm not gonna worry about it. But there's a lot of psych on the NCLEX. I mean, it is a big content area, so it's. Okay, so let's see how much you remember. Nagel's rule. What's Nagel's rule?
Oh, the last month, last.
First day of the menstrual period.
I was close.
You're close. That's the first part of it. Very good. Very good. Minus 3 months plus 7 days. Okay, good. What about gravidipara? I used to say that you're never going to get a question on gravidipara because it's too easy, and then they put it on a HESI last year. It's like, wow. Gravid is how many pregnancies you've had versus how many deliveries. Okay, and if we use the TPAL, so T stands for term, and what's term? 37. 37 completed weeks. P stands for preterm. Parent, preterm. Okay, so T is term, P is preterm. That's between what?
18 to.
This is gravida.
36.
Okay, yep, 20. 20 to 37.
The beginning of 37.
Yeah, or we can say the end of 36. A is what? Yep, which is loss after less than how many weeks? Less than 20, right? And then this gets separated into spontaneous, which we would call a miscarriage, and Yay. Here. You want to leave me 2 more? Or you want to leave me the pack? Thank you. Okay, what else prenatally?
Folic acid.
Can we test for folic acid?
No, we get both.
Yeah, we give folic acid. What else can we do on a lab test? We,
What about GBC,
very good. GBS.
GBS?
When do we do that?
Right before
Not
they
at the
give birth?
beginning, before they give birth, right? So 35 to 37 weeks.
They can get it on the vaginal canal when they come out.
Right, right. And
Yeah,
because
What's GBS again?
group B strep,
That's the one to figure out.
group B strep, right? And the reason that we don't test for it early is that even if we test it early and we treated her, it's probably going to come back.
Yes.
And we're probably not going to get rid of it, right? So we want to test close to delivery so that the baby doesn't contract it on the way out. Okay, good. What else? What about an H&H? Why do we care about an H&H and a platelet count? What about anemia? Yeah. This one, right? We want to know what our baseline is. What happens to our H&H during pregnancy? It goes down, right? We have that physiologic anemia of pregnancy because of the increased production of red blood cells. And then we know that the baby's going to take whatever iron it needs, right? So we want to know what our baseline is so that we can treat it before so we don't get in trouble with a hemorrhage. And what about platelets? What do they do? Clotting, clotting. Good, good. Okay, did we get them all? Okay, let's think about screening tests for chromosomal abnormalities.
Chromosomal abnormalities?
Yeah, so what do we test for? What are their? So the first one is cell-free DNA.
Oh, what we do to test them.
Yeah, and we do this one around 10 weeks. And then the next one, remember, is this MSAFP, maternal serum alpha fetoprotein, AKA a triple screen, AKA a quad screen, AKA a multiple marker, right? All the same thing, basically. Testing for the amount of alpha fetoprotein in the blood, right? And if the screening test is positive, then we're going to do a diagnostic test.
Not a full mark.
This multiple marker.
A lot of deviations.
Sorry.
The first one was that.
Maternal serum alpha, fetoprotein. Yeah, sorry. Maternal serum alpha fetoprotein. Okay, this one's done around 16 to 18 weeks. Okay, and this one will tell us if she's at high risk for a chromosomal abnormality or if she's at high risk for a neural tube defect. And if the test came back positive, then we would go to the next test. So what's our diagnostic test for chromosomal abnormalities? An amnio, very good. There's another test we could do early around 10 weeks that's also diagnostic.
That's the one where they go into the placenta, right?
Yep, yep, chorionic villi sampling, right? And why don't we do that for everybody?
Right.
Because you can cause a miscarriage, right? Yeah, or you could cause a limb deformity. It's pretty invasive, right? So we would be better off to start with either this one or this one, okay? This one, for a while I was seeing it as brand names on the chart, but now I'm seeing this non-invasive prenatal testing. I know. I know. We can. Let's do it. If you got it on the nclex, I don't think you're going to get it on the nclex because it's not been around that long. But it's been around more. You never know. It's been around more than 5 years now. Okay. So chorionic villi sampling, cell-free DNA, which is the non-invasive perinatal testing, 16 to 18 weeks of maternal serum alpha fetoprotein, right? And if it's positive, then we're going to do an amnio. Okay. What would be our diagnostic for a neural tube defect? If you want to be able to see it, right? That nuchal translucency is trisomy, is chromosomal. But after 18 or 20 weeks, I might be able to see it on ultrasound, depending on, like I should be able to see an anencephaly. I might be able to see meningocele. We might just have to wait for the baby to be born. Okay, what test do we do at 24 to 28 weeks?
CVS.
This is 10 weeks. These are 10 weeks. Yeah. 24 to 28 weeks. What am I worried about? Getting out of control. What disease comes on in pregnancy sometimes? Diabetes, good. Okay, so I'm going to do my glucose screening here, right? So if I do a glucose screen, if I have her drink the disgusting stuff, right? And then do my blood glucose, and let's say it's 200. What am I going to do next? The 3-hour test, very good. I'm going to do it again, right? I'm going to draw a fasting, have her drink the disgusting test, and then test her blood at 1 hour, 2 hour, maybe even at 3 hours.
So the first one is how long they wait?
You just drink the stuff and test in an hour.
Is that the one which is called
The glucose?
tolerance test?
Yeah.
Right?
Yeah.
Well, yeah. It's a 3 hour. They're gonna check us out. Okay.
Yeah,
It's like,
right.
but if you're, it's the 3 hours.
If it's, some labs do 2 hours or 2 of them, some do 3. If my first glucose is within normal limits, then she doesn't have gestational diabetes, right? She can drink the disgusting stuff and bring her glucose level down, then all is good, right? Okay. What do we know about diabetes in pregnancy? Does it get better or worse? It gets worse, right? What are the potential effects on the baby?
Big baby.
Big baby, yeah.
Hairy.
We can also get, if she's been diabetic for a long time and her sugars are all over the place, we can get birth defects, and we can get a really small baby because she can make a really crappy placenta. But if she's just got gestational diabetes, we're probably going to get a big baby, right?
Does gestational diabetes go away after they give birth?
Theoretically,
Not the cure? Because someone asked me that yesterday and I literally said, I think so.
for most women, it does. A lot of the maternal fetal medicine literatures, those guys feel like if you get gestational diabetes and you have a predisposition to diabetes, and at some point in your life, you probably are going to be
It
diabetic.
goes away like after birth.
It should go away after birth. Yeah.
There's probably those that might be like pre-diabetic anyways.
Yeah.
And like that just like kickstarts it.
Yeah.
And then they have it. Right.
And then they
So
have it.
yes or no? So yes and no.
Right.
Depends on the person.
Depends on the person. Right. Okay. Did we get all the prenatal stuff? I think we did.
No.
Okay. Let's go to physiologic changes of pregnancy. Now our dark line. Okay. What are the skin changes? Linea nigra. What else? What happens on your face?
Myasthenia gravis.
No.
What?
From pregnancy? No. Let's hope not.
Brown spots. Nobody knows about
Melasma. Melasma.
Don't put those
Asthma.
on the test.
That's in the recording.
Don't put those two on the test. I'm just confused.
Sometimes people use colasma.
Isn't that the face?
Yeah, that's the mask of pregnancy. Yeah,
So
yeah, kind of like, not pimples, but just like darkening of the skin, like right around here. Yeah, which should go away. And then just plain darkening, remember, of the areola. Okay, and striae, right? Which could be on your legs or on your belly, or can be pink or white or silver. A nice variety, right?
Some pimples on there.
Okay, I started on skin. Skin's not even on here.
That's
Oh, there it is. It's on the bottom. Okay, yeah.
On the face.
Okay, which way do we want to go? Up?
Sure.
Sure. Okay, so we already know that we have I don't think we'll get questions on changes in the vagina, but we might get the leukorrhea, the increased discharge, right? Which is there to kind of flush out any bacteria. Remember, the job of the body is to keep the bacteria out of the uterus so that the baby stays safe, right? So the cervix is supposed to be closed and there's supposed to be mucus there, but then there's also just kind of an increased discharge to wash out anything that's bad. Okay, GI. What's our favorite hormone at the beginning? Our pro-pregnancy hormone. Progesterone, prolactin too, but progesterone, right? Progesterone is that keeps the uterus nice and relaxed, but remember it also works on the GI system.
Makes you dark.
So it makes you, not the other way. Yeah, prostaglandins make you, yeah, prostaglandins come later, right? So initially we have progesterone, which helps relax everything. So that's going to give us decreased GI motility, decreased GI movement, so constipation. And then eventually the progestin levels are going to go down and the prostaglandin levels are going to go up. And what do prostaglandins make you do? They make you, yeah, they cause activity, right? They make smooth muscle contract. So that's why they make the GI system contract. So now you're going to get some diarrhea, right?
What makes the hyperacidity? Acid levels goes up in GI.
We have a delayed gastric emptying. That's part of it. And then sometimes they get reflux because the baby pushes on the stomach, right? So it's kind of pushing up this way. So you have a kind of some of that GI reflux stuff. But otherwise they should be okay.
About the grinding, like it increases the production of HCl,
Oh, of HCl?
hydrochloric acid.
Does it?
Yeah.
It might. Yeah, it might.
Hyperacidity.
Yeah.
There's a little like.
Good job.
See it?
Okay. Breasts, we talk about estrogen, right? We have increasing the breast. The prolactin is going to kind of build those milk ducts, right? With the letting down. Respiratory. We do have generally kind of some swelling or nasal stuffiness. Remember that pregnant people are hard to intubate. The airway stuff, sometimes we get extra nosebleeds. But otherwise, her respiratory rate shouldn't change significantly, except when she's in labor, right? Okay, nutrition, your favorite. I know.
Iron and vitamin C.
Iron, vitamin C, and what else? Folic acid. Okay, good. Give me some foods high in iron. Red meat. What about chicken? Chicken's high in iron. Yeah. What else?
You said liver.
Liver. Yeah. Dark red meat. Eggs. He's like, sure, eggs. Eggs, beans, legumes. Yeah, remember our little acronym, eat lots of iron. Okay, vegetables are high, not in iron, but in what? Green leafy, they're high in vitamins and folic acid, right? And then remember that enriched grains and cereals are enriched with iron and with folic acid, right? Other vitamins too, but for us, what we care about is the folic acid and the iron.
Vitamin C drink? What, orange juice?
Orange juice, yeah. Yeah. So why do we want to drink orange juice with our iron? It helps absorb it, right? Yeah. And if we don't absorb it all, then it passes through our stool and that makes us more constipated, right?
They like the test on that. If iron, what's it gonna do to your stool? Is it gonna make it darker?
Makes it darker.
Yeah,
Uh-huh.
that's right.
Yeah. Yeah. The whatever's not absorbed passes through. Yeah.
Yeah.
Okay, musculoskeletal. What happens to your joints? What's the hormone that messes with your joints a little bit, that makes us waddle? There's the relaxin, right? And then we end up getting lordosis, right? With the changing center of gravity. So we have kind of a little sway back. Okay, good. What about those ligaments? Remember we have the broad ligaments that come from the back to the side and the round ligaments. Which way? They come up this way, right? Okay, cardiovascular. What happens with our blood volume? Increases by how much? 50%.
Wait, the blood volume increases 50%?
Uh-huh.
Wow.
Sorry, I was thinking back more nutrition. How many pounds is it supposed to be per week? 2?
Yeah, 1 to 2. Like 25 to 35 pounds is a normal weight gain for full pregnancy, right? But somebody that's overweight is not going to gain as much, and somebody that's underweight may gain more.
50% more.
50% increase in blood volume. Yeah,
12 liters, you now have 24 liters.
I know that's a lot, isn't it? That's crazy. We think about it. So what's the increase? What parts of the blood increase?
You have 12 liters, but you increase 50%.
You'd add 6.
Yeah,
Not
you don't become
12.
twice the person.
Yeah, that's 100%.
Tell me.
But you are growing another person.
You are growing another person.
Half of a
Yeah.
person.
Yeah. So remember, we have an increase in like a 25% increase in red blood cells, but a 50% increase in plasma. So that's how we get that physiologic anemia. We end up with a net decrease in our H&H because it's more diluted. And that happens around the second trimester. That increase in blood volume, I'm sorry, happens pretty initially. So like 6 to 8 weeks, and then it peaks at like 28 weeks, that increase. And then what happens after she delivers? She's got to get rid of all of it, right? So when we have somebody that has a cardiac issue, that's the big deal on the cardiac issue. Those are dangerous times, right? Because you're putting an increased workload on the heart. Okay, urinary frequency,
Gotta pee her pants.
right? Yeah. Worse in the first trimester when the baby's sitting right there on top of the bladder. And then in the second trimester when the baby kind of comes out of the pelvis and it's not so bad. And then in the third trimester when he settles back into the pelvis, then it's bad again. Good. So because frequency is something that she feels all the time, it kind of what is she at risk for? UTIs, right? She doesn't usually feel the burning, and she got frequency anyways, right? So we want to dipstick urines every time she comes in. Good. Remember, there's also that decreased renal threshold for sugar, which means that sometimes she might just spill a little sugar in her urine, which is okay, as long as it's a small amount, especially if she's been eating a bunch of sugar. Okay. Okay, uterus, we talked about that. It increases in size, it increases in weight. We went over the other things. So bad getting old, you guys. Not read this.
Yeah.
Okay, what about the vessels in the cord? How many?
3.
And what are they? 2 arteries and 1 vein. And which one, it's backwards, right? So which one brings oxygenated blood? The vein. Very good. Very good. Okay, here's a little just study guide to, we're going to do meds, and then we're going to do fetal monitoring. Yay, you'll remember them. You got a good review yesterday on your postpartum hemorrhage drugs.
Thank you.
Those are the ones, Hemabate is probably the one they'll ask, if they ask one. Methyl-orgonadine, carboprost. I think that's why they asked that one, because it doesn't sound anything like Hemabate.
Yeah.
Whereas the methyl-orgonadine is like
And
flu.
Cytotec is.
misoprostol.
Misoprostol.
Yeah. Yeah. Okay, what's our first one? Oxytocin. Okay, what's the other name for oxytocin? Good. What kind of drug is it?
What's your theory?
Okay. Hormone, what does it do? It's a oxytocic or a uterotonic. Okay. What do we have to worry about?
We need to worry about.
Oh, what is it used for? What's it used for? Okay, so when she's in labor, we're gonna give it to her titrated in very small doses to make her have uterine contraction. Sorry,
You worry about too much?
I worry about too much.
Well, that would be
We
like
end up
every
with
30 seconds,
atony.
every contractions every 30 seconds would be too much.
We want at least 60 seconds in between contractions for good relaxation. Okay, this is the classification. Yeah, it's a hormone, it's an oxytocic, it's a uterotonic.
What do you mean by
Also-
oxytocin?
I know, it causes contractions. Sometimes you'll see oxytocic. I know, it's weird. Uterotonic makes more sense. Okay, so it makes us have contractions, so we titrate it in labor, right? in milliunits per minute. And what about postpartum?
Bolus.
We usually bolus. You can also give it IM postpartum, okay? So in postpartum, we're doing however many units in a bag of fluid, right, at milliliters per hour. Okay, usually they just open it up. Okay, what do we have to watch for? What do I have to watch for over here?
Hypertension.
Yeah, okay. So I want vital signs for mom and baby. So heart rate, fetal heart rate, right? Contractions, frequency, right? Because if they're too close together, I'm gonna slow down my PIT, and if they're too far apart, I'm gonna increase my PIT, right? Do you remember those funky words for too many contractions? Tachysystole. Sometimes I see hypertonicity. Yeah, or hypotonicity. So it's just talking about if the contractions are too close together or if they're too far apart, right? Okay, what do I need to worry about postpartum?
With oxytocin.
Yeah, what's supposed to happen?
Correction.
Right, right. I should have, my fundus should be firm, right? And midline.
So can't they be unresponsive sometimes to it?
Yeah,
Yeah, it can be, the receptors are too
Yep.
worn out.
yep. Which is now why they're even saying we should be cautious with that bolus. Because at some point it's not going to work anymore because the receptors are all filled. Okay, so what is it called when my fundus is not firm? Boggy, right? What about if my fundus is boggy and it's not midline, it's up and over to the right? The bladder is full, right? So we need to empty the bladder. Okay, good. Okay, so she delivered and we did our pit bolus and it's not working. So what's my next drug? What's the next one we have on there?
Really, you tell them? Preterm.
Oh, that's preterm. Yeah.
That could be the next one, right?
Yeah, here, turn on to the next page. Here's postpartum hemorrhage drugs. Let's do methogen. What's the other name for methogen? Methyl, or this is not spelled right. Methylogarnivine. Okay, it's also a uterotonic, right? What do we give it for? Postpartum hemorrhage, how do we give it? IM, good. Who cannot have it? Not with hypertone, right? Right, because it's a vasoconstrictor. It's a really powerful vasoconstrictor. Okay. Okay, what's the next one? Sorry.
It's 4. Tiny bit.
Okay. And what do I want to watch for? I'm giving it to make her uterus contract, right? So I should, if it's working, I should have a firm fundus, right? So I'm still looking for uterine bleeding. And because it's a vasoconstrictor, I should also be watching for blood pressure, right?
Especially if they're also on like the dose and stuff.
Yeah. Okay, now what's the next one? Which is hemabate, right? I think I have them backwards here. Carboprost. Okay, it's also a uterotonic. What do we give it for? How do we give it? What's the really bad side effect? Yeah, huge, huge.
Yeah, with the odium.
Yeah. Who can't have it? Asthmatics. Methogen is sensitive to light. It comes in a brown ampule. Hemabate has to be refrigerated. And you can actually also give it right into the uterus. You're in a C-section. Okay, and what if I'm successful, what happens? My uterus contracts.
Yeah.
Right?
Wait, you said hemabate has to be cold?
Yeah, it's
And methogen has to be.
methogen is light protected, yeah, so it's in a darker ampule. Okay, what's the last one? If neither one of those work, What's the other name for Cytotec? Good. What kind of drug is it? Is it a prostaglandin?
Yes.
You might be right. Yeah.
That was arbopros is a prostaglandin too.
That makes sense. It's also a GI drug, right? So if you're giving GI upset, so if you had that patient that came in that was complaining of GI upset and you gave Cytotec, what do you have to check first? Pregnancy, because you can cause her, make her have a miscarriage, like if she doesn't really know she's pregnant yet. It's also a uterotonic. Okay, what do we use it for? It works for postpartum hemorrhage. It also works for cervical ripening. So this one for postpartum hemorrhage, I'm giving a big dose, like 800 to 1,000 micrograms. And this one I'm giving a really small dose, right? Because if she's hemorrhaging, I want that uterus to be super contracting. But if I'm giving it for cervical ripening, then I don't want tachysystole, right? I don't want my uterus to go crazy contracting. So I give it in very small doses. Remember, it's a little teeny tiny white pill. And for cervical ripening, I'm going to slide it up, put it right by the cervix. And once it's absorbed by the mucous membranes, I can't take it out if she contracts over too much, right? So usually they do 25 to 50. Okay. Remember, it comes, this is the one where you have a huge number of pills that you're giving because it comes, I think the highest concentration it comes in is a 200. A lot of times they stock it in a 100 micrograms. So you could potentially be giving 800 to, or 8 pills, 8 to 10 pills. How do we, I'm sorry, how do we give it? Rectal, yeah. Why do we give it rectally? Because they're bleeding, right? So if we slide it up by the cervix, it's just going to come out. But when we're doing cervical ripening, it can go by the cervix because there's nothing coming out, right? What if she had ruptured membranes? Would this be a good drug to give? No, no.
Isn't this kind of first line? Is Cytotec one of like the first drugs they give because of the side effect profile?
There are some people that give PO Cytotec right after the placenta comes out prophylactically. That does happen. There are people that are like out in the rural areas that like, they give everybody prophylactic Cytotec. But otherwise it kind of depends on the practitioner. You know,
When I saw the C-section, they put uterus before closing.
before closing.
Yeah.
Yeah, that makes sense.
They just like put some pills in there. I said,
Kind of crazy, right? But it's the same thing as plopping them up there by the cervix, right? And they're just going to get absorbed.
The birth I saw, she immediately got Cytotec, but she wasn't even bleeding at that.
Orally,
No, rectally.
rectally.
Yep.
Yeah, I think that's a little overkill.
I think it was because she was in labor for like 22 hours.
Ah,
But she
okay.
wasn't bleeding that bad.
Okay, but they were worried about her uterus being tired, right? So prophylactically. Yeah. Yeah. All you have to do is have one really bad hemorrhage and all of a sudden you're, you do a lot of prophylactic stuff. Like you're just a lot more cautious, right?
because
Yeah. Okay. Front page. What are the drugs we have there? Okay, so labor. Drugs we use in pregnancy. So Pitocin still works.
are there any side effects? Are you on it?
There shouldn't be. There's nothing really exciting, just the regular ones.
Okay.
The big one is that if you're early pregnant, it could cause a miscarriage. There was a Law and Order episode about that. Uh-huh.
SVU?
Yeah, maybe.
SVU episode.
Oh,
Was it an SVU episode?
Oh, I-
Or was it Law and?
An SVU episode.
they're good. What's the shame?
Yeah. A boyfriend who
It's insane.
like gave her Cytotec without her knowing about it.
I did the same sometimes that.
I know. How'd you get your man?
Was he a doctor?
No, he wasn't a doctor. I don't think he was. He was a student. He was a college student. Okay, what's terbutaline? What's the other name for terbutaline? No,
Oh.
but it starts with a B.
No.
Breathing. Breathing. Okay, Yeah, breathing. Okay, what does teredoline do? What kind of drug is it? It relaxes smooth muscle. It's a beta mimetic. So because of this, it's primarily an asthma drug, right? Remember, the lungs are smooth muscle and the uterus is smooth muscle. Okay, so what happens when you take a nice little puff of something for your asthma? What happens to your heart rate? Yeah, your lungs relax, right? But your heart rate increases, right? Okay, so we give it for preterm labor. And we need to watch for a maternal heart rate and a fetal heart rate because they will both go up. And so we don't use it very much anymore because it doesn't just increase your heart rate, but sometimes it gives people chest pain and MIs.
Perfect.
Yeah,
Love stroke.
right. Not good.
So.
Not good. I saw somebody, we used to give it IV. Saw somebody give an accidental bolus of teredoline once. It was not good.
What if they have a really bad day?
They do give it to asthmatics. Mhm. Sometimes in pediatrics, they put it in a syrup and it's called Bricanyl instead of breathing. It's just the stuff in a syrup. But when we do it, we give it sub-Q. Yeah.
This is, oh, to stop labor.
Yeah, that's how we use it, to stop labor, right? Because it relaxes the uterine muscle as well and it works pretty quickly. Yeah,
Betamethasone is the one for.
it relaxes the uterine muscle, right? So we should have no contractions. What, Caden?
Betamethasone is the one for the lungs.
Yes, yes. You want to do that one next? What's the other name for betamethasone? Celestone. Or sometimes they'll just say corticosteroids.
I think it's on here.
Oh,
It is. It is.
sorry,
It
it's over. Celestone.
I mean,
Shut your trap.
Yeah. So it's a steroid. And we're giving it for what?
lung.
Uh-huh. To increase lung maturity. Who's? Baby. Right? So if I have somebody that's in preterm labor, right? I can think about giving a drug that would buy me some time. Oh, we had somebody else at Passport. Yay! Our summer people.
Wait, who?
Our summer people are passing boards.
The last semester's number one, in the class, someone, what's her name?
Madison?
Yes.
Yeah, she passed a couple weeks ago. Yeah, there's like 15 or 20 of them that have taken a pass. A bunch of them are taking it this week too. And they're all getting different stuff. Yeah. She's gonna do good. She's gonna do good. Okay, increases fetal lung maturity. How do I give it? I am. 2 doses, 24 hours apart, right? It's long-term steroids would cause weight gain, maybe an edema, right? But we're just giving those 2 doses.
How far?
24 hours apart is ideal.
Yeah, there's not really any side effects to watch for.
There shouldn't be because you're just giving 2 doses. Yeah. And you're not really going to know if it works until the baby comes out. It's either on the vent or it's not, right? Okay, mag sulfate. Is that the next one? Okay, what kind of drug is it? It is an electrolyte, but that's not why we're giving it. What are the, yeah, it's not an antihypertensive, it's a vasodilator. So one of the side effects is that the blood pressure goes down. Okay. What's the primary reason we give it? Yeah, so it's a anticonvulsant. And it's also a CNS depressant. I know, it's a lovely little drug. Right? How do we give it? You can give it IM. The only reason you would give it IM is because you have somebody that's seizing and you're having a hard time giving IV access. Because it's 10 milligrams and it's 1 milligram per mil. So it's a 10 mil injection, which even if you split into 2 injections is 2 injections of 5. Yeah, not good. Like we used to give it that way every 4 hours. And then people, I mean, the nice thing to do is to mix it with lidocaine so it doesn't hurt so bad, but then you're given 6 mils, so yeah, so that's not good either, right? Yeah, and you get funky blood levels, right? So IV is the way to do it, right? Remember we do a 4-gram loading dose and then 2 to 3 grams per hour after that. Okay, so when I do this 4-gram loading dose, what's going to happen what's this vasodilation effect? How's she going to feel? Tired, lethargic, heavy, hot,
Yeah.
right? Okay. This CNS depressant, what's going to happen to her reflexes? They're going to decrease, right? So from like 4+ brisk to hopefully 2+, right? What's going to happen to her respirations if we give her too much? Decrease. So what are our 2 markers for toxicity? Decrease. Yeah, hopefully decrease respirations. Hopefully we see, we fix it before we have loss of consciousness, right? That's bad.
The big ones
are.
These are the big ones, right? If they ask about toxicity, diminished DTRs is what we see first, and then we see decrease for respiratory rate, and then if we don't do anything, then we see loss of consciousness. And then we have a code.
That level is like 8, right?
Yeah, we're going to like 6 to 8, right? So remember our normal level is 1.5 to 2.5, and we're trying to get somewhere between 6 and 8 or 5.5 and 7.5, somewhere in there.
Symptoms at 12.
At 8 or 9. Yeah. Anything over 8, we're going to start seeing symptoms. Okay. So what do you want to be checking on her every hour? DTRs, respiratory rate. What else? Blood pressure, heart rate. Who else's heart rate? Baby's heart rate. What else? You got somebody that's preeclamptic. What else do you want to check?
Edema.
Yep. Edema. What else? Temperature would be fine, but what else? How do you get rid of mag sulfate? How does your body get rid of it? Through your kidneys. So what else you want to check? Urine output, right? Because remember, worsening preeclampsia, a sign of worsening preeclampsia is a decreased urine output. And if you're giving mag and your urine output goes down, what happens to your mag level? It's going to increase and you're closer to toxicity, right? Lung sounds, sometimes we see pulmonary edema. Think about other signs and symptoms of worsening preeclampsia. Visual disturbances, epigastric pain, like visuals, like seeing spots in front of your eyes or floaters or headaches, worsening headaches, periorbital edema. You want to check all those things, okay?
What is this? What's the thing called? Is it HELP?
HELP syndrome, yeah. HELP syndrome is a derivative of preeclampsia. So what does that stand for?
Hypertension.
No,
Elevated something.
Hematic.
What is that?
hemolysis.
Hemolysis.
Oh, help. I remember.
What are these? This one is elevated liver enzymes. So that's an elevated AST and an elevated ALT and low platelets. So less than 100,000. Right. And the liver enzyme thing makes sense because she's complaining of epigastric pain. So as the liver enzymes go up, the liver actually gets bigger. And so it's putting pressure over here, therefore the pain, and you could actually have a ruptured liver. HELP syndrome, which is a derivative of preeclampsia. Yeah. So we would treat it with mag sulfate. Okay. So we're only running that mag sulfate to buy us time, right? You can't leave somebody on mag sulfate for weeks at a time, right? So we're going to have to deliver the baby, right? And if we're lucky, we can at least run mag for 2 to 3 days so that we have time to get a steroid in for the baby, right?
What was that 1.5?
That's this is the normal range, the normal magnesium level. What's the antidote for mag sulfate?
Probably good. Calcium gluconate.
Calcium gluconate, good.
Protamine sulfates for heparin and lemnos.
Good. Okay, do we get all the drugs on the table? I don't know if I made a table for the baby drugs. You want to do baby drugs real quick, or should we go to fetal monitoring?
What are baby drugs? Surfactant?
There's.
Erythromycin, vitamin K, and
Hep B.
Hep B. Yeah,
No, we are.
we're good. Okay. Okay, let's do fetal monitoring.
That's our.
Okay, when I look at a fetal monitor, I'm looking at rate. What else?
Frequency.
Frequency, yeah. Which would be contractions. Okay, accels or decels. Oh, did we not do cervidil? Sorry. We better do cervidil, and variability. Is cervidil on there?
Yeah.
Okay, cervidil is a prostaglandin. Right?
What's the name?
Cervidil is the brand name. It's a prostaglandin. I mean, it's just, we used to just mix prostaglandins in KY jelly, put it in a syringe and shoot it up there.
That's great.
That was the initial one. That was the Wild West. Yes, that was the Wild West. We used to mix our own pit too, you know, and then Joint Commission at some point said, oh, you guys are compounding. You're not allowed to do compounding unless you have a hood and, you know, only the pharmacy can do compounding. So we don't do that anymore. So yeah, back in the day when you did it, that was probably like 10 cents a dose. Now it's hundreds of dollars. Yeah, cervidil just takes that prostaglandin and it puts it on like a little gauze, and it has a string on it, so that when you slide it up into the uterus, you can take it out. Yeah. Yeah, yeah, exactly. Only it goes higher.
So it's used for
Yeah.
cervical. Right?
It's used for cervical ripening. Mhm. And just like with Cytotec or with Pitocin, you could have tachycystole, you could have contractions that are too close together, right? And if that happened, in this case, you just pull it out, right? So you want to be monitoring the baby. That's the advantage of this over Cytotec or, you know, the Wild West mixing your own. We could do a good, you know, like good trivia game on stuff we used to do, because some of it's really unbelievable.
Yeah.
Even for me when I think back on it.
Yeah.
Yeah. Yeah. Sharpening needles to be
Dipping
re-sterilized.
dipping ice cream in like.
Ice cream in the placenta freezer.
Yeah, that one stuck with me. Oh.
Yeah. Yeah, we did crazy stuff back then. Okay, did we finish cervidil? Okay, so now we're on fetal monitoring. Okay, so I'm looking for the rate, the variability, which is these squiggly lines. So we're gonna do a nice one first. Do you remember our acronym?
Go shop.
You guys are so good. You remember it all. Okay, so my rate should be between what?
120 to 200?
110 to 160. I think we're on the bottom of page 1. Or, yeah, we're on page 1, at the bottom of page 1. Yeah, you were right. Yeah. So what do you guys see up there? What kind of changes are those? Those are accelerations. So which part of this is it? It excels, and it means what? The baby is oxygenated, right? Remember A-OK. Yeah. Okay. So I'm looking for a rate between 110 and 160. I'm looking for moderate variability, which is the squiggly line. So it's not just 120, 120, 120, 120, right? It has variation in the heart rate. And that variation in the heart rate tells me that my vagus nerve is intact. Do you remember which cranial nerve that is?
Good.
Very good. You guys are so smart. It's insane, isn't it? How much you know?
That's such a great.
Susan Greathouse says that you know more now about every part of nursing than you will ever know in your entire life.
And that's scary. 'Cause
You know more, you know a lot, Lauren. And then you're going to go out into the work world and you're going to know whatever your field is, you're going to know that super well. And some of the other stuff is going to fade away, which is okay too. Yeah. Okay. What about what's V is variables, right? And what does that mean? Not contraction, chord compression. What do they look like?
They're mirror.
No, those are earlies. V, chord compression, remember? Yeah, right? If I took my hand and put it around your neck, so they look like, and squeezed, right? Your heart rate would go, it would tank, right? And it would stay that way until I released. So they look like V's or W's or U's. So somehow the cord is getting squeezed, whatever, and then it gets unsqueezed. And as long as they come back up, we're not that flipped out about them. Okay, because the baby's tolerating. So we could have cord around the neck, could have knot in the cord, could have cord in the hand and he's just playing in there, you know, could be up against the shoulder, whatever.
So like the intervention for this is change position.
Change position is a good one, right? What else can we do?
Nothing.
Put it in the cord up.
No, that would be if I did cord prolapse.
Oh.
This is just a cord compression. So our interventions for our bad stuff are almost always the same. Change position is always the first one. That's the least invasive, right? How can I send more fluid to the baby, more volume? I can do that by increasing IV fluids. And then I can put oxygen on mom, right? Which puts more oxygen in her blood, which sends more to the baby.
Can you stimulate the baby's movement at all? Do that by turning.
Turning her is probably, sometimes people try, vaginally will try and like rub on their heads. You know how your mom used to? Yeah.
I saw that thing where like it's the 5-finger.
Yeah, like a noise thing. Yeah.
Yeah. Oh.
Yeah, we used to do that, just like, you know, like
They
buzz
still
them.
do it.
Yeah, bzzz, you know, it's supposed to, yeah, it's supposed to like wake them up.
Yeah.
Yeah, that'll work. Okay, what about earlies?
Head compression.
Yeah, very good. Okay, now I need contractions.
Head compression is bad.
Head compression is not bad. We expect head compression at some point, don't we? Okay, so they start when the contraction starts. These are the ones that mirror. Yeah, I don't think those are very good. And they end when the contraction ends, right? So they're gradual. What are our other words? Inverse. They might mirror. Sometimes people say they mirror the contractions. They're inverse proportion. It just means that if I was looking at my monitor paper and I turned it upside down, yeah, it looked kind of the same. Yeah, right. So head compression, not a bad thing. What do you want to do? You've not been seeing these all day and all of a sudden there's a bunch of them.
Did that baby out?
It probably means the baby's coming out. So what do you want to do as a nurse?
Okay.
What do you want to do before that, Lauren?
Check the
Check the cervix. Check the cervix, right?
Call a doctor. So
Yeah.
if you haven't done at least 1 to 2 seconds.
Yes, right. They don't want to wait around, but they also don't want to miss it. So it's right. Yeah, so you're supposed to be you're supposed to know exactly when the baby's going to pop out. Okay, those are head compressions. Okay, what about lates? Very good. So they start.
Take that out.
It's literally right here.
Oh, see, I was so, you didn't have to tell me that.
Right here.
I read the thing.
She read the thing. Okay, so they start after the contraction starts, right? And they don't come back up until after the contraction's over. So they're late to return, right? And that is placental insufficiency. So what's happening there? What is it? It means that I don't have enough oxygen in my placenta, right? So baby's fine for a little while, right? Because there's no blood flow to the placenta during the contraction. And then I run out, and then here's where I get my new blood supply, right? So change position, right? What's my worst position to be in? Laying on my back, right? How come? Vena cava, we're compressing the vena cava, right? So we're not, so sometimes just changing the position is all it takes. Okay, I still have lates. What's my next thing?
Oxygen.
Yeah, what's least invasive? Yeah, oxygen or oxygen IV fluids, right? Most of the time people do IV fluids first and then they do oxygen. Okay, I still have lates.
Maybe lower pit.
Yeah, lower it or turn it off.
Yeah.
On the NCLEX, the answer is going to be turn it off. I know in practice we see lower it. Apparently they're getting very picky about that too. Like your order set having to be very specific, not just about how much you can go up or how much you can go down. Joint Commission, thank you those guys. Yeah, well, you should just bump it up and down at our will. But now you got to have orders for that. Okay. Okay. So turn off the pit, notify the provider. Right. Okay. If this continues to happen and we also have poor variability, then we're probably having a C-section. Right.
The accelerations are good, right?
Accelerations are good, means the baby's well oxygenated. Yeah. I don't think I put this on the paper. Well, what do you think this is? It's like 60.
It's gone down.
It's gone down. It's a prolonged deceleration. Okay.
Check, you know, sure.
Check.
Check.
That's on the, what should I check? I should check her, right? Because maybe we have a cord prolapse, right? That would be a reason for an abrupt drop that stays down there. So if I have a cord prolapse, what's my action? No, there you go, Shelby. Yeah.
Right now, and I asked Paul, like, what's a prolapse? And he was like, isn't that when it's wrapped around the neck? And I was like, no, get this. And then I told him about it and he was like, that's.
That is insane.
Cause they like give videos at what you're supposed to do on the field, like.
Yeah.
Literally are like, do not hurt this baby, make sure it gets to us.
So if you rush to C-section?
Yeah.
Yeah.
If you rush a C-section,
Absolutely.
right? So what would your position? So we're going to elevate the presenting parts usually ahead, right? What I don't want the baby coming out. So we either do hands and knees or Trendelenburg, right?
You do that one in cord compression, or you do it in maybe.
Cord
pre-
prolapse.
Oh.
Cord prolapse. Hands and knees. Oh, hands and knees is a great position. We don't see it here because everybody has an epidural.
They were like hands.
You read in the, what I'm starting to read is about the bridge presentation.
Yeah, to kind of, because you want to get it, hands and knees kind of, the reason it works for a prolapse is that when you're on your hands and knees, the baby kind of falls out of the pelvis, releases. So if you had a breech, it would make it easier for it. Opens the pelvis. Yeah. Yeah, it's a great position. But not one normally done in Corpus Christi.
At what point do you remain like your fingers there in that position?
That would be a cord prolapse. Yeah, somebody has to hold the presenting part off of the cord until you get to the OR. So whether you're riding the bed from the labor room or you're out in the field and you're in the ambulance. You don't have very long, right? I mean, if you compress the cord, that's the baby's lifeline. So you go longer than. No, because what's coming, that would be easier.
What are you doing with the finger? Are you putting
You're
it
pushing up the, no, you're pushing up the head.
ahead?
Yeah, because the cord has come down and the head is coming after, and so the cord is stuck between the pelvis and the head. Yeah, so you're pushing the head up so that there's no pressure on the cord.
So you leave the cord there.
Yeah, you can't push it back up. Yeah. There's a big loop of it down there. It's not gonna work. You're just pushing the head up. Yeah. Just a little cord prolapse.
What about the cord around the neck?
You can't do anything about that until she delivers, right? Then we'll pull it over. But we can't fix it. Okay, obstetric emergency. So the first one is a cord prolapse. What's the next one? An abruption. Very good. Let's do abruption. And what's the other one, Lauren? I don't know.
Where it's left inside.
Placenta rupture, placenta previa.
Okay, so is it on the sheet somewhere? Do you guys need a break? Or are you okay?
5 minutes.
I'm doing great.
There's no such thing as a 5-minute break. It's always 10 minutes, but yes, we can do a 10-minute break.
Should the 10 minutes should make me feel better?
We get out of that, huh?
We're gonna get out of 10, yeah.
What is the baseball?
But it has negative effects.
Oh,
Sure.
What about
You
we
guys made
close
it
this here?
equal. Any of the oysters.
Oh, okay, we're on placenta previa and placenta abruption, right?
You know, 90% of all that's needed for it.
That's wild.
Yeah, but. We got stuff, right?
That is what passing.
That's not very nice
The 70s, well, that's why we get 11 points back on. It's really like.
I was kind of worried about your capstone scores, I have to say, and then,
Oh, y'all can't.
Good, they're horrible.
yeah, we can see. I just looked this for the first time. I'm like, I don't have a frame of reference, but then, D, well, whatever, doctor, whoever, you know, I'm like, is this where they're supposed to be? And she's like, yeah, that's about where they're supposed to be. And I'm like, oh,
It's really a humbling experience, though.
I said, okay.
How humbling. I'm supposed to sit in the 50s for pharmacology? Where we are. That's where
And we're gonna try and get in the 60s. It's gonna get better.
Oh.
See, if you, well, I mean, we're aiming for the 70s, right? We're always aiming for higher, but the feedback is that you guys are like not, there's like no big danger signs. You know, that like you're way off track, like you're where you're supposed, like, you're in line with,
If somebody feeling like I'm in the danger zone, because my ATI says I'm at risk. I'm regular.
well, you're all at risk right now, but you've.
You don't have risk if you want. I'm not at risk.
I mean, this is the way to look at it, okay? You're
never at risk.
we're on week 4.
Well, but this is like.
We have, we have 11 weeks left, and then you have another 6 weeks.
We have 87 days.
No, it's not, it's like.
You will be, when you sit for your NCLEX, you will be ready. This, what you're supposed to be doing is filling in your gaps, right? Most of us have gaps. We have things that we really remember and things that we really don't. Yeah, so,
87.
yeah.
One, but I'm this, I'm like, no, it's there in the computer.
Okay, come on. Let's fill in our OB gaps. What's an abruption? The placenta comes off of the wall of the uterus. Okay, so what are the symptoms? What color bleeding?
Red.
What? Dark, not bright red, dark red.
Wait, what, really?
Dark red, yeah. Yeah, because remember, it's up high, yeah, and it travels, so it's older blood, right? So dark red bleeding, pain. Okay, what are we gonna see? If it's a big one, okay, even though there's a separation, the uterus is still sending that blood in, right? So what are we gonna see with her blood pressure? We're gonna see a decreased blood pressure. What are we gonna see in our heart rate? An increase in heart rate. What are we gonna see with the fetal heart rate?
Oh, baby's not delivered yet?
Baby's not delivered yet, no. What are we gonna see?
Yeah.
What kind of deceleration?
Late T cells?
Late D cells, yep. And maybe poor variability, right? Because you're not sending enough oxygen to the placenta. Okay, what about a previa? What does that mean?
Lying
It's in front of the baby, okay? So what color blood do I have? Bright red. Is there pain? Yeah, no pain, right? Because that blood is coming from the placenta and it's right there on top of the cervix. And my cervix starts opening and it's like pulling those placental vessels. And so it's fresh blood coming out. So that's why it's bright red, right? And the cervix isn't a muscle. The pain comes from blood sitting on muscle, right? So up here, is it possible I don't see any blood at all? Yeah, it could be completely hidden, right? I could, yeah.
Wait, how do we diagnose?
Bright red blood?
Well, we diagnose on pathology and on ultrasound, but if you have, but it's usually post-delivery, right? If you have somebody that's all of a sudden got significant pain and you have these kinds of situations going, you're going to make an assumption that you have an abruption and you're going to the OR. And then you'll pull the placenta and be like, oh, whoa, yeah, look at that. We had an abruption. We'll send it to pathology to confirm, right? If you were going to confirm it on ultrasound, that's going to take longer, right? So you're only going to do that if it's a small abruption and your baby is stable. Otherwise, you're going to the OR. Okay, what about this one? Bright red, how's she delivering? C-section, absolutely a C-section, right? Okay, so remember with the previa, sometimes we get a warning bleed and then the bleed stops. Okay, and so we just have her hang out in the hospital and we're just watching the baby, right? And we're trying to buy some time. So what drug are we going to give her? Because we're buying time. not mag sulfate.
It's less, so.
Yes, yes, we're gonna give her celestone, betamethasone, right? Right, if I'm worried about her delivering early, anytime I'm worried about her delivering early, we're gonna do steroids, right? And then otherwise, I'm gonna schedule my section at, 37, 38 weeks unless she has a big bleed. And if she has a big bleed, then we're going to the OR right away. Okay? Why do we keep her in the hospital? Why not let her go home?
Butylene, that's what we do that too, right?
If she's if she's having contractions, yeah. But she's probably not having contractions. Yeah, if she has a bleed, by the time she got to the hospital, the baby could be dead.
Wouldn't
she
she
could-
know previa?
Hmm?
Wouldn't you be able to tell if they have placenta previa?
Ultrasound, so like you might have seen a low-lying ultrasound at a routine ultrasound. Yeah, yeah, and then you would be doing more serial ultrasounds. Yeah, and the day before all those mega ultrasounds, people came in with a bleed first. Okay, what's our other uterine problem? Yep. Okay, what do I have here?
Low blood pressure.
Absolutely. High heart rate,
and
Right.
Prolonged B cells.
huge pain. What does it feel like? What does she say? Yeah, we are gonna see lights. She's gonna say it feels like something's like something's tearing apart, right? What does my uterus look like? If if it opens up somewhere, then I don't have pressure from all sides, so I don't have my nice round belly, right? The shape looks different. Yeah, it looks a little different, and maybe I see like even a hand or something under the skin. Yeah,
That's why
I know, it is crazy, right? It is crazy. Yeah, so the big one is pain. And then we're definitely gonna see lights, and she's gonna talk about a tearing sensation. And this stuff is gonna happen really fast because remember there's like 600 mils a minute going through the uterus. And so if it opens up and that blood is coming out into the cavity, she can bleed a lot in a very short amount of time.
So that's what I'm taking, it's gonna be emergency.
Yep.
medicine type
Yep.
of-
Yep, so what kind of anesthesia are you gonna choose?
Yeah.
Absolutely. Okay, so we got, Hmm?
Maybe.
for, yeah, so, remember that, a risk factor, let's think about risk factors, would be, previous uterine surgery. For whatever reason, that little blastocyte, he's supposed to implant up at the top, but he kind of heads down to where that scar is. The risk for, an abruption is anything that causes vasoconstriction.
Trauma.
Trauma, smoking, cocaine, high blood pressure. Anything that causes vasoconstriction can cause an abruption. A rupture, previous uterine surgery before, yeah, especially previous C-sections, laboring after a previous C-section, trauma too, yeah. Yeah, usually we see them with a VBAC.
Even give you a title like says.
So abruption and previa would be DNC treatment, right?
C-section treatment, not DNC.
Oh,
DNC is
You wanna get
still
that
have some of the placenta left inside, right?
Right,
well, if it was an abruption, isn't that what it is? Isn't it left?
No, it's removed.
but she's pregnant, there's a baby there, right? So we're gonna deliver the baby, and when we do a section, we're gonna go in there, and we don't have to do a DNC because we're gonna open up the uterus and we're gonna stick our hand in and pull it all out.
How are you diagnosed?
Pain, vital signs late, yeah, pain, maybe dark green bleeding, what's happening with my baby, bright red bleeding,
So it's a little.
no pain, right? Do I want to do a vag exam on this person?
No.
No, 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 right? What about my other funky things like accretas?
Creative is going through the muscle, right?
Yeah, right. So how do I know? If I'm lucky, I see it on ultrasound, but if I'm not lucky and she has one and I don't know about it, what's gonna happen? She's gonna come out, the baby's gonna come out, right? And the placenta is either not coming out or it just comes out in pieces, right? And if there's still something left up in there, she keeps bleeding and we go through our whole range of stuff and nothing happens. So then we go to the OR and then we do a DNC, right? And we can't get it out, or maybe a manual removal. And so what's the ultimate solution? A hysterectomy, right? Right. Okay, did we get all the, I think we got all the emergencies. Placental stuff?
What do you do for a shoulder dystocia?
Oh, we didn't do a shoulder dystocia. Okay, very good. So what's happening in a shoulder dystocia?
Oh, we break the
Very
collarbone.
good. See, look at you, you know all the noise. Yeah, so the shoulder gets jammed up against the pubic bone, right? So what kind of baby is more likely to do that? A big baby, right? So babies, my diabetic moms, those are the usually, right? And they come out, the head comes out, they had that little turtle sign that comes out and like it can't, it's jammed. And so it almost looks like it gets sucked back in, right? So the head is out and the shoulder is stuck. So McRoberts maneuver does what? That's suprapubic pressure. What's McRoberts? Legs up, right? Because we're trying to, that's McRoberts. Yeah, pulling both legs up and back because we're trying to tilt the pelvis forward. So the baby's head will kind of relax a little bit. We're not going to turn the baby, then we're going to do suprapubic pressure. Suprapubic.
So breaking the collarbone is like worst case scenario?
Yeah.
But their bones are like collagen, so it's okay if it breaks.
Better a broken collarbone than a dead baby or brain damage. Yeah, we'll take that. Right. I mean,
Like jello bones.
maybe they could break the tailbone.
No.
It's a tailbone supposed to be,
Kids fall down before you break my tailbone.
Please don't break a steel.
they're supposed to be the mother's tailbone, not the baby.
God,
That's why I'm saying. Break your kids' collarbone.
A life
before my
of
tailbone.
sciatica.
Yeah, yeah.
pinch
The
nerve.
tailbone is supposed to be movable, but some people have one that's not as
Take
movable.
that kid's bone.
Please don't break the bone.
We're just gonna get it out however we can.
He has jelly bones, I know.
Yeah.
You would also recover.
Exactly.
I'll never be able to walk straight again.
Okay, let's talk about anesthesia. Oh, Victoria, you're gonna text me one of these days.
Not happy if I text you one of these.
Okay, I have a broken tailbone.
I'm gonna say my daughter's sign.
Just make sure everything goes okay in my delivery.
Okay, just sit in the corner. That sounds good.
Yeah, start telling them. No, actually, that's not what you. I'd like you to.
Yeah, they won't like me.
They won't like me. But in the corner.
Okay, here's our mom. There's her belly.
Wow, she's beautiful.
It's beautiful, right? Okay, what's the difference between an epidural and a spinal?
Epidural is an infusion
Where,
in epidural space.
right? And the spinal goes into the spinal column, right? That's the difference. So the epidural space sits right in front of there, and so when they inject the drug, and then they thread the catheter and give you a continuous infusion, you have like medication kind of dripping down here, and so you should get relief going down, right? Okay. What's the most common side effect of an epidural?
Oh, the CF. Like, that's how whatever.
Oh, no.
Oh, like.
Hypotension. Hypotension. Epidural. Hold your thought, Lauren. The most common side effect is hypotension. And so before we do the epidural, we do an IV fluid bolus. Yeah. Okay. And then hopefully we don't get hypotension. If we get hypotension, then we're going to give more fluids. Then what? How do you feel when you're hypotensive? Just lethargic, clammy, yeah, nauseous, right? Dizzy, maybe. Okay, so think about Noelle. So what's the next thing we're going to give? We're going to do a fluid bolus, and then what would we give? Oxygen, right? Yeah, oxygen, and then the CRNA can give ephedrine. Spell it wrong. Okay, but that would be our next thing, right? Position change, right? Sometimes after, remember after the epidural goes in, they put the Foley in, and so a lot of times you've got somebody laying flat on their back, which doesn't help, makes them even more hypotensive. So better if you can put a Foley in where they're not exactly laying flat on their back, or if they're wedged or something, or do it fast so you can flip her over. Okay, now, Lauren, if I mess up, I meant to do an epidural, but I went too far and I went into the spinal column. Now what's my big risk? You said it earlier. I used a big needle and I went into the spinal column.
Oh, this.
Now I can have now I can have spinal fluid leaking out, right? And remember, we have a closed system here. Goes up to our brain, right? So if I have spinal fluid leaking out and it takes me a while to make spinal fluid, every time I sit up, I have a bad headache, right? Yeah. Okay, so if I have a spinal headache, what can I do for it? I need to promote increased making of, I want to make more spinal fluid faster. So fluids. Caffeine actually helps with the headache a little bit. But then what's that procedure they do? If none of that works and we think the fluid is still leaking out, we think there's still a hole here. What are we gonna do to?
That's the circulatory pressure, so spinal tap,
I don't want to do a spinal tap.
or you just.
I want to plug it up. I want to plug it up. What am I gonna plug it up with? The name just left me. A blood patch. A blood patch. Yeah, a blood patch. So they go and they draw blood from her, just a little bit of blood, and then they inject it where they put the needle in, and hopefully it clots and it seals off the hole. Right, so can we do that as nurses? No, so our job would just be to like assist. Watch, get the stuff, right? Monitor blood pressure, stuff like that, yeah. Okay, my spinal, if I do it on purpose, right, I'm using a skinnier needle so that when I pull the needle out, the hole closes over, right? What happens if my spinal goes too high? My level goes too high.
CNS or respiratory depression.
Yep, respiratory depression. Good. Good. Okay, what about a general? Yeah, intubated, right? So that's the first problem, right? Is that pregnant women are sometimes hard to intubate, right? Sometimes they'll ask for somebody to do cricoid pressure. So as they're putting the tube down, you're pushing here to just to kind of isolate the, yeah, kind of help isolate the trachea. Goes to the baby really fast, right? Floppy baby, so you gotta go fast, right? But it's the fastest, right?
The order is epidural spinal jet.
Yeah, these both are regional, so either one is okay. I've seen people do a spinal for labor, but it's that C-section is going to be a general. Yeah, yeah. If it's not an emergency, we'd rather do either an epidural or a spinal. We used to do epidurals here all the time, and both places for C-sections. They came into triage, you put your epidural in, then we put the Foley, and it was great for us because we got to put in all those Foleys. And then we went to the OR. But you know, sometimes it took a while for the level to get up, and I don't know, it just took longer, and we were behind all the time. And so now they take them to the OR, have them pop up on the table, they do the spinal, lay them down, put the Foley in, and work out. It's just faster. But an epidural works fine for a C-section.
Spinals are quicker than.
Spinals are quicker. You get your level quicker. Yeah.
How quick?
Spinals are about 5 seconds.
It's going right into the spinal fluid.
When you're in there because you get.
Yeah.
Yes, not anyway.
Right.
Epidural, you have to have a loss of resistance.
Yeah,
And that's hard.
to make that space, right? And then sometimes people get one-sided epidurals too, right? So it's not, yeah. So it, yeah. Those guys are good that do those epidurals all the time on spinals. Okay, did we get all the emergencies? I think we did. I actually have a slide thing for you. I'm just going to show it to you. You may not need to see it all. I think we hit everything on the slide. Oh, but it's not under this module. It's under module file because it wasn't going to be this time.
It was like directly. Did it feel like an? I think it was applicable.
Yeah, here it is.
I think Sarah, she's saying go to place. But as if we're not.
Oh, that's the wrong one.
Sorry.
Oh, yeah. When are we getting our exam? With Brandon?
That is on my list this week.
You have it, made?
That is weird.
Can't hate.
Why is it downloading?
I probably won't be. I should
I'm gonna go get Rondo. You see it. I'm sorry, I don't know. That was a joke.
Okay, my file is not downloading right, so I'll put it in somewhere else. For you guys to be able to see it. Okay, there is,
It's so hot.
there is in module 4, like a 13 slide PowerPoint just on delegation, but I think you guys feel okay about delegation?
Yeah.
Yeah.
Okay.
What
Yeah.
is our first exam gonna be over?
Um,
Everything we've done? Cause on the
When is
module,
it?
it says, it's not over anything that we talked about.
man, it's every content so we're focusing on management of care,
Yes.
health promotion, psychosocial integrity, and what's the other one? Basic care and comfort?
But is it gonna be
Like
over,
over med surg and over.
is it gonna be over like our
There's-
research?
It's gonna pull from all those things.
But not-
so- But like health promotion, OB is a lot of health promotion, psychosocial integrity. That's why I was trying to get that psych
It's
review,
gonna be something we've kind of been over at class, right?
hopefully,
Okay.
but not all of it. But I'm gonna give you a blueprint. Right? You're supposed to know it all.
Yeah.
It would
And
be
remember it
nice
all.
to brush up.
We're trying to brush up. Okay, do you guys have any questions?
Oh, I don't know.